Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm very pleased today to be talking with Dr. Ben Kligler, a family physician who is Executive Director of the Office of Patient-Centered Care and Cultural Transformation at the VA. He's also professor in the Department of Family Medicine at Mount Sinai and does some teaching in the Family Medicine Residency Program. And he's the creator and leader of the Whole Health Program that the VA is very actively engaged in. So, Ben, thank you very much for joining with me today.
Happy to be here, Larry.
So, I'd like to start off with a little background. How'd you end up going to medical school, and then how'd you end up going to becoming a family doc?
Well, let's see. My dad was a doctor, like a lot of physicians, so I did grow up with kind of a sense of what it was like, and a sense of what the rewards were potentially, and also a sense of how hard they worked. Um, then I went to college and honestly wasn't sure I was going for medicine. I was an English major. Ultimately, what happened is I got interested in ethnobotany. I was very interested in the outdoors and in plants, and then that sort of ended up steering me to the medicinal uses of plants. And then that sort of steering me further to looking at different ways of healing and different ways of different cultures approached health. And so then, kind of in a roundabout way, ultimately, I decided, well, I do think I should do medicine. But then it wasn't so simple because once I started in medical school, I suddenly felt that the things I was learning and the approach in the first couple of years of basic sciences wasn't really wasn't what I had been looking for, and it was hard for me to see how it was going to take me to where I wanted to go. And so I actually took a leave from medical school and spent some time thinking and working and reflecting and toying with various ideas, including going to acupuncture school, becoming a musician, sort of all the other things that could have potentially done. But then I actually had a job to support myself during that time at an outpatient psychiatric day program in Boston, where I got to do direct sort of patient care with people with chronic mental illness. And suddenly it just seemed really clear that, working with people inside of the healthcare system was what was the right path for me. So went back to medical school, finished it up. And then it was quite clear to me that family medicine was the way to go, because I knew that what I was interested in was the whole person. And I knew that family medicine was also the specialty that was most open to the kind of outside the box thinking about health and healing that I was interested in, most open to the idea of complementary therapies being part of the toolbox. And so it was a pretty much of a slam dunk of a decision for me that was the way I was going to go. It was the place where I saw a philosophy that really matched up with mine, and because I had already struggled through the ways in which the traditional medical paradigm didn't actually match up with mine, it was quite clear that in residency this was where I should go. I had the good fortune to go to the Montefiore program in social medicine, where again it was very much oriented towards not only the whole person, but real biopsychosocial thinking in terms of how social factors, social determinants of health, the community, the environment, how it all fits into people's individual health. So that was also a really great fit and kind of got me launched to where I wanted to be going.
Fantastic. So how'd you get connected up with the VA?
Well, I finished training a long time ago, obviously. So I taught in a residency program for a while. I then helped start and run an integrative medicine center in New York and built out a research and education program there, et cetera. And then somewhere down the road there, a colleague who I had gotten to know through my integrative medicine work, who is Dr. Tracy Godet, called me up one day and said, Ben, I have an opening for a new position. It's director of the Integrative Health Coordinating Center, which is in charge of uh, standing up and spreading policy for complementary integrative health within the VA system. And, who do you think I should call to recruit for this job? Because Tracy knew that I had been involved nationally with a lot of integrative medicine organizations and I knew a lot of people. And I just said, how about me? And that was kind of the road forward from there. And I will say, just a caveat, Larry, you said you gave me credit for being the creator of the whole health program in the VA, and really credit for that goes to Tracy, who was in my job before I was. And so I'm happy to be currently shepherding it, but it needs to be said that Tracy was really part of getting it started, who unfortunately is not a family doctor, an OBGYN, just goes to show that there are some creative people in other specialties too. So credit where credit is due. But basically what happened, a lot of why it was interesting to me and why I decided to come to the VA, there were two major reasons. One was, I started into family medicine because of a sense of commitment to care for underserved populations and to really push kind of for social justice as part of what I was doing in my work. And then over the course of time, as I got more interested in integrative medicine, I ended up in more or less of a middle class practice and not so much caring for what I would traditionally think of as underserved populations. And so when the VA opportunity came along, it suddenly was a very natural opening to sort of turn back in that direction and think about working with a population that was more challenged and more, not that veterans are underserved, because I think the VA serves them really well, but obviously a population that's dealing with a lot of very unique and challenging problems. So, and the second reason was that, I had been working for years really to help carve out a place for complementary and integrative therapies inside of conventional medicine, and doing that at Beth Israel and Sinai and in some national work, and making a lot of progress, but also feeling like, well, this is just one hospital, and it's such hard work to get it off the ground even here. And how do we ultimately do this on a bigger scale? And then when the VA opportunity came along, here you are, 140 medical centers, 1,000 outpatient sites, 6 million active patients, ready to kind of endorse and embrace this idea of integrative health. And so that was sort of too good an opportunity to turn down, really. That's how I ended up there. And then a couple years after I arrived, Tracy actually left the VA for an outside job running a new foundation interested in whole health. And so then a couple of years ago, I moved into the executive director job where I am currently.
So can you describe the whole health program? What's it all about?
Yeah, well, the core idea of whole health is this idea that what's most important in taking care of our patients is understanding what matters most to them in their lives, what's most important to them, and really making that the centerpiece of how we try to help with their lives and their healthcare. So going beyond disease-oriented care into this realm of creating health, creating well-being. It's very consistent with the family medicine model, really, and what pulled me into family medicine. But even in family medicine, because of the drivers in the system and the incentives and sort of the pressures on us, we really do end up taking a pretty disease-oriented approach and identifying treatment plans according to a list of diseases. And this is the idea to step back and say, who is this person? Have the conversation with them about what is most important to them, and then specifically talk to them about what kind of skills, what kind of assistance do they need to move towards what's important. So that's like the core concept, but then it has some specific shapes that it takes when we put it into practice in a medical center. So it has three components. One is pretty unique to the VA, and it's called the Pathway Program. And this is where veterans have the opportunity to meet with a fellow veteran, a peer, who's been trained in facilitating conversation around life goals and directions. They get to have a conversation with a fellow veteran either in a group setting or individual setting, or now, in many cases virtually, where they start to have that conversation about what do you want out of life? What matters to you the most? What do you need your health for? And they also start to have the conversation about, well, what areas of self-management or self-care could you do better in? Are you doing well in, let's say, how you're eating and drinking? Are you doing well in your social relationships or your spiritual life? Or can one or more of those areas need some help? So they start to help a person look at their potential resources and where they might strengthen those. Second part of the whole health system is called the well-being program. And in the well-being program, veterans have the opportunity to work potentially with a health coach. They also have the opportunity to receive a range of complementary and integrative health approaches. VA is now covering a number of different evidence-based complementary therapies like acupuncture, Tai Chi, yoga, meditation, biofeedback. These are covered now as part of VA standard medical benefits. So veterans have the opportunity to access that bigger toolbox to help them deal with whatever it is that they're dealing with in their life. And also there's a big emphasis on learning skills. So whether that's Tai Chi, meditation skills, whatever it might be, nutrition, that's really a core part of the system, is the idea that we're empowering people to not just necessarily look to the medical system for a fix, but to be able to look to themselves for the fix. And then the third part of the system is we call whole health clinical care. And the idea here is that, of course, people still do have diseases. They still need surgery. They still need physical therapy and medications. But what we're after is that the clinicians or the clinical teams that treat them ultimately are also aware of this idea of treating the whole person and treating the person in the context of understanding what's really important to that person, not necessarily what's important to me as the physician or the provider of care. And so we're embarked on a very large, really kind of amazingly large program to help educate VA clinical staff about what does this mean to think about a whole health approach and how do you put it into action. And in fact, just last week, we were part of a 3-day virtual conference that was co-sponsored with primary care and mental health in the VA, and we had 3,000 attendees from across the country, mostly primary care and mental health staff. And it was a really interesting conversation about, well, how do you actually do this kind of whole health approach in a busy primary care practice, in a busy mental health setting, when there's a lot of other pressures on you? How do you bring this forward in the conversation with the veteran? It was and it's not simple. It's a complicated equation. And, people in any health system have a lot of pressures on them, but in some ways VA has some particular pressures. And, but at the same time, people are very motivated to do it. They really see the point. And so our job is to help figure out how do we remove some of the barriers to people taking that approach. And I'll just say one more thing about it. The really interesting thing, sometimes I go and I give a talk, grand rounds, or et cetera, to a group of physicians about this. And they say, well, what's really different about what you're describing from just doing good primary care? And the answer, I say, is nothing, really. The only thing you could point to that might be different is this expanded toolbox of options. The average primary care doc doesn't necessarily have access to refer to yoga, Tai Chi, acupuncture. But in terms of the core of it, understanding what's important to your patient and then putting their treatment planning in that context, that is good primary care. And so in a way, it's just raising up and I don't know, what am I going to say? Reviving, re-endorsing, revitalizing kind of a really core concept that's been there for a long time, certainly in family medicine for sure. So it's a great challenge. We're making great progress, I would say, in VA.
One of the things that really strikes me, based on what you said, Ben, and I do think this is kind of radical in many primary care practices, the focus is on let's figure out what's wrong. It's kind of as you said, disease oriented. Let's figure out what's wrong with the person and fix it. And when you talk about helping people identify their life goals, that doesn't happen everywhere. I think that is pretty profound.
Yeah. Well, I would certainly agree. I mean, I think it's not what we think of traditionally as the role of the healthcare provider, but I think we've lost a lot of the potential impact we can have on people by cutting ourselves off from that conversation, right? Because if, someone may not want to live forever, but they may really want to accomplish something important to them in the meantime. And they may be, um, uh, it may be that their treatment plan needs to be adapted, refined, focused around what is it you want to do with your life, and what is most important to you. And so it gives you a great opportunity to kind of really um, go where people are, as opposed to try to drag them to where you are, which is a lot of what we do in conventional healthcare. So I do think it's radical, and I think the other thing about it is it pushes us to think about the concept of well-being, and what do we really mean by well-being? Do we just mean the absence of disease, or disease that's well managed, or do we mean a life that's full and where meaning and purpose are evident and kind of right out in front every day, and where a person is connected with the things that give them strength in their life, and and then whatever happens to them in terms of their health per se, um, happens in that context. So for me, health is only one dimension of this bigger concept of well-being, or a life that is um, enlightened by well-being, I guess you could say. And I think in particular the pandemic also brought home the power of that in some ways, because we saw that people that were most vulnerable and did in some cases the worst were people who were not already set up. There were people whose health was not kind of well supported and well attended to, and so I think it really reinforced this idea um, of building up the inner strength of the person as part of the role of healthcare to be prepared for whatever comes. So I think it is radical, really, and in a very exciting way. I could say more about that if you want. I can keep going.
Well, let me come back to that. I'm sure, being the VA is the government, and this is a very broad program. You've got some very interesting evaluation strategies working. Can you give us some idea about the impact of this program and how much of a difference it's making?
Yeah. Um, so we had the good fortune uh, that Congress passed a piece of legislation in 2016, I think it was, called the CARA legislation. It was the Comprehensive Addiction and Recovery Act. And one of the things that large piece of legislation mandated was that VA choose a set of demonstration sites in which access to integrative health and whole health would be expanded to, particularly to the population of veterans with pain, but really to everybody. So starting in 2017, we started working with 18 specific VA medical centers around the country who got sort of specifically chosen and then specifically supported with some special funding to stand up this whole health system in a more complete way. It's happening all around VA, but it's happening at different rates in different places. So at the flagships, it kind of got a turbocharge and was able to stand up much more quickly. And as part of the congressional mandate, we had to produce a report back to Congress 30 months into the project on what were the outcomes that we were seeing. So we worked with VA health services researchers to build out an evaluation strategy where we looked at what were the implementation challenges, very important. What was the utilization like? In other words, were veterans really interested in this approach? And then what kind of outcomes would we see as a consequence? And we were able to do a very large patient-reported outcome survey called the Veterans Health and Life Survey, where we used a conglomeration of about 8 or 9 validated measures looking at different aspects of people's lives. And we were able to recruit a group of about 7,000 veterans from these 18, we call them flagship sites, and follow them over time with repeated surveys and looking at things like Um, Obvious things like pain scores, but then things also like life meaning and purpose, perceived stress, um, engagement with their healthcare, self-efficacy. Also, of course, physical and mental quality of life, opioid utilization. And so we were able in that population of veterans to really show pretty impressive benefit in a lot of different areas. Just as one example, veterans who used the whole health system in the flagships who were on opioids were able to decrease their dose of opioids much more quickly than veterans who weren't engaged with the whole health system. That was one thing we found. We also found that veterans, there's a standardized measure of life, it's called the life engagement test, and it's generally speaking a measure of whether you're finding purpose and meaning in your life. And we were able to show movement in a positive direction on that measure as well in veterans who were engaged with the whole health system because somebody was talking to them about what was important to them. So obviously that's going to help you start to think about that and figure that out. And so a number of other domains as well where we saw changes, but uh, and then of course we were able to demonstrate that a large number of veterans were interested because over 30% of the veterans at these 18 sites who had a pain diagnosis did choose to participate in some way or another in the whole health system. So it wasn't like, oh, that's a nice idea, but people aren't going to be interested in really participating. So we saw really positive outcomes in all kinds of domains, and we still have a lot more outcomes coming. There's a lot of data still we haven't gotten fully analyzed, and I think we'll be seeing more coming out fairly soon.
So are you able to say, for example, in traditional health services research, you're looking at decrease in uh, uh, morbidity and mortality. You're looking at decreased cost uh, downstream
Yeah,
for a given population. Do you have any metrics like that you can describe?
we are still working on the cost outcomes. Right now, we're working on our health services colleagues are looking at a population of veterans with severe chronic back pain and their utilization of invasive spinal procedures like injections, et cetera, epidurals, and looking to see what happened to the utilization in a group that started using whole health. Did it change their utilization of particularly this type of spine procedures, or compared to a population who didn't use whole health? And we haven't got that data in yet, but there's kind of early signals that yes, we chose that because that's a particularly expensive and particularly ineffective conventional strategy, and also has risks attached. So we're going to have data soon showing whether we can show specifically a decrease in costs there. We're also looking at utilization of other services, diagnostic testing, emergency room, et cetera. And that's still going on. We don't have that cost data yet. In terms of mortality, uh, 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 that's so tough because there's so many confounding factors when you're doing, an observational study. So I'm not sure we'll be able to produce data that shows change in kind of a specific cause of mortality in a given population. One thing we are really interested in because veteran suicide, I mean, suicide in general, but veteran suicide in particular is a huge problem and of great interest to the VA and the whole country, really. And we have a notion that this concept of loss of meaning and purpose in life is an intermediate risk factor for suicide, obviously. And so if we have an intervention that potentially can help people reconnect with their purpose in life, is there a chance that that will help reduce risk of suicide? And that's something we're really interested in. Again, it's a hard thing to measure because how do you know if a person has never had a suicide attempt, what do you know exactly what their risk of suicide is at a given moment? But the mental health folks nationally in VA are very interested in helping us look at that, trying to roll out this approach more actively to kind of a more high risk population from a mental health point of view, and then seeing what happens with suicide attempts, suicide gestures, et cetera. So that's something we're going to be looking at in the next year or two.
So, I mean, this just sounds fabulous, and I commend you and your colleagues. for putting all this together and putting it in play. What are you learning from this that you think might apply to non-VA settings?
Yeah. Um, well, I think most of what we're learning potentially can apply to non-VA settings. I think we're certainly learning that not everyone in the patient population, but a substantial proportion of people are interested in this. They do want to have this kind of conversation with their care team about what matters to them in life. And for some people, it's really enabling them to be more of a partner in following through with the specific disease treatments because they feel like they're on a team. We're learning that the role of health coaching in helping people get to where they want has tremendous potential. I mean, the feedback we get from veterans about the work they're doing with their health coaches and what kind of impact it has in their life is tremendous. And there are a lot of outside health systems that are engaging with health coaching now, but I think just over and over again we hear from veterans what a huge impact that has. We're certainly learning that the use of non-pharmacological treatments for pain can help you reduce overuse of medication. I think that's obvious, and I think in the outside world, one of the big barriers to making that happen is the lack of coverage for the complementary integrative health approaches. And so having removed that barrier inside the VA, we're certainly seeing that, amazing benefits for people with chronic pain and people who are interested in taking less medication. I mean, not everybody should or can stop opioids long term, but many people would like to, or would certainly like to decrease their dose, and giving them more options for how they manage their pain is definitely a big part of that. But those options have to be covered. You can recommend something to somebody. If it's not covered and they don't have the resources, it's a bit futile to recommend it. And so we have that kind of opportunity to look at what happens with uptake of the complementary therapies when people don't have to pay a lot out of pocket for them. And we know obviously what we're seeing is really great results from that. So I think I think the other thing we're seeing is that among employees, clinicians, clinical staff who engage with this kind of approach, we see VA does something called the All Employee Survey every year, and it asks a lot of questions about your experience as an employee, but it includes questions about burnout, about turnover intent, about is VA, quote, a best place to work? And what we're seeing there is that employees who are engaging with the whole health kind of orientation also have lower burnout, lower turnover intent, higher kind of engagement and satisfaction scores in their work. So we're also seeing data that would suggest that ultimately this is not any kind of magic answer for burnout, because there's so many contributors to burnout, but that it's one of the potential inputs that can start to have an impact on reducing some of the burnout we're seeing in healthcare. So all kinds of lessons, and I think more to come, really.
That's very, very exciting. What's next for you?
For me personally?
Yeah.
Well, I'm going on vacation next week and doing a backpacking trip with my son in Yosemite. So that is very exciting to have that be next.
Have you been there before?
I have, yeah, several times, and I just love it there.
Spectacular place. Yes.
Oh, fabulous, yeah. And so that's what's next for me. But I mean, I think in the bigger picture, I'm really excited about seeing this spread across the VA. I think what's happened now is that a couple of years ago, this was still our office kind of trying to push this concept forward. And I think now we really have a lot of uptake and engagement and understanding from other parts of the system, so that this is now kind of getting propelled forward from a much wider base than it was a couple of years ago. I think that's exciting. I think one thing I'm really excited about is exploring more the challenge of measuring the impact of this on people. So I was talking a little bit about well-being, as now we're going into this realm where part of our job is promoting well-being, or Don Berwick has this term health creation that he coined a while back, which I just love, as opposed to just health promotion, but health creation. And we don't have a lot of good measures in that space. We have measures that can look at well-being from a research point of view that are, 80 questions long and take 45 minutes to fill out, but we don't have too many measures. We do have more measures now that are brief and easier to use, but we haven't seen really any health systems on a large scale incorporate those into the routine kind of conversation with patients. And so we're really interested in kind of pushing that part of the envelope in VA and making part of routine patient contact or engagement, having a tool that asks about well-being specifically. Are you doing what you want to be doing in your life? Are you fulfilling the roles and functions that are important to you in your life? And are you moving towards what's important to you? And so, I think if we have, and we do have a measure that's been validated and we're trying to pilot it as part of routine clinical care, because I think if that became part of what's routinely asked about in the medical encounter, then you start to also make an impression on patients about the importance of taking charge of your own life, taking charge of your own health, and looking at it that way. And I think that has a lot of potential to move the dial on where we are with this. So I'm excited about learning more and doing more in the area of kind of measurement and using that as a tool to leverage more change, I think.
So are you familiar with How's Your Health?
I'm not.
So John Wasson, who's an internist up at Dartmouth, has been working with the Dartmouth Co-op. I'm not sure if you know about that, but they've been around for, oh my gosh, at least 25 years. And it was a group of primary care folks that were connected up with Dartmouth in that neck of the woods. And they've been working on practice transformation for all these years. They developed this tool called How's Your Health, which has been funded through federal government grants, which means the tool itself is free to everyone. And it really focuses on, it's patient driven, and it's a series of questions, relatively brief, that patients can answer. They get at the issue of well-being and their confidence in their ability to manage their own care.
Mm.
And they have learned that question is, how confident is somebody, if asked, how confident are you that you can manage your own care, is in a critical one. And if you focus on the people who say not very confident, you in fact can have a dramatic impact, because those are the people who are the ones who need to be called back, need to be worked with. So whatever needs to be done to help them develop that confidence that they know what to do and how to handle their condition. I can send you a link to it and you can take a look at it. It's
Yeah.
and if you'd like to talk to John, I'd be happy to connect you up with him.
Yeah, that
Really,
sounds very much in line with the kind of conversation we're trying to have, for sure. Absolutely. Yeah, love to look at that.
so the other question I have for you is, in a way, you're sort of in a contained space, being that it's the government um, government initiative. I'm wondering about the implications for health systems. Everybody in the country now is talking about the transformation to value-based care. And it seems to me that the whole issue of patient empowerment, um, and their ability to identify what's meaningful in their own lives so that the clinical systems can support that, um, including well-being, that's really at the essence. If you're really going to improve the quality of health services and you're going to reduce the cost of care, what you folks in the VA are doing, I think, is instructive for everybody. And I'm just wondering if there's any thoughts about how you're going to get the story out and how you're going to help the other systems learn from uh, a government sponsored initiative.
Yeah. Yeah, I think we're always trying to get the story out. I mean, I just had an experience a couple of weeks ago. There was a panel at the National Academy of Medicine, not a panel, a workshop on financing for whole person care. And it had lots and lots of people from, a fair number of people from government, a lot of policymakers, and then a fair number of people from kind of the payer world, and a few clinicians. And I got to share um, how our model is potentially viable in looking at, there was absolutely uniform agreement, of course, across that whole spectrum of people that value-based care is where we need to be going for the most part. And I was able to share with them how we're doing that in the VA and what kind of response, what kind of uptake we're getting. And people are very interested. And actually, one of the things that came out of that meeting is some conversations I'm having with some folks at CMMI, the Center for Medicare and Medicaid
Yep.
Innovation at CMS, because they're very interested already in the idea of how would CMS move towards engaging with measuring and paying for whole person care. What would they be measuring? What would they be asking people to do? And so they're very interested in what we're doing in VA as, just one of the ways that you might try to tackle that. So I think there's a lot of interest in the bigger healthcare world in this subject. And I mean, I think one thing that is important is, people talk about value-based care, but then sometimes they stop short and they say, okay, well, that means, did all your colonoscopies get ordered? And did, okay, well, what proportion of your population quit smoking? Tremendously important, right? But they stop short of asking the patients what outcomes are most valuable to you, and then setting up the value-based care equation based on, are we giving patients what they need, as opposed to us establishing what we think is value in healthcare and then making that the target. Because if we do that, then value-based care won't get all the way to where it could, right? Because we'll still be focused on the transactions and the referrals and the procedures. Whereas if we can get to, let's say we have a validated well-being measure and it's administered to patients twice a year as part of their coverage, and systems that manage to help generate movement in a positive direction of well-being are rewarded with higher reimbursement rates. I mean, can you imagine what that would look like? And so I don't see why we can't do that, honestly.
Right. That would be very exciting.
Yeah, yeah, and you can do that without losing the emphasis on disease treatment, health promotion, disease prevention. I mean, it can be part of the package. And from my point of view, if you're supporting people around what's important to them, and restoring meaning and purpose in their life, they're a heck of a lot more likely to go get their colonoscopy, right? I mean, I can't prove that to you with numbers yet, but I think ultimately it only makes sense that if we can engage with people in a more complete way, that's going to ultimately propel the value in all these other areas of healthcare too. So I mean, that may be a pie in the sky, or overly optimistic, but I think that's what we need to explore next. But that means that we need to be routinely measuring well-being so that we can see whether these things really go together. If we stop short and we're only measuring number of colonoscopies or number of people who quit smoking, or we're not going to find out what's really possible.
We're still trapped in the transactional model.
Yeah,
As
exactly.
opposed to the relational model.
Yeah, yep. So, but I will say, I just think there's tremendous interest in this outside. I think there's interest in other parts of the government, including CMS. I think there's payers that are very interested in this also. And, I mean, just honestly, I think that there's, it's hard to see with all the other messes going on, but I think there's a real shift in our society towards people being in charge of their own lives and their own health and their own choices and their own well-being. And I mean, ultimately, I think that's what the millennials are bringing to the fore, and that's where we're going to end up. And so I think we have to be really proactive and creative in thinking about how to engage with that. But it's that change in society that's allowing this conversation to happen, right? It wouldn't be happening if a bigger change weren't happening. We wouldn't be able to be having this conversation, and we wouldn't be able to be getting the interest and traction that we're seeing from all these different sectors. So, I mean, we have so many problems to deal with in our country, but I think there's also, at the same time, there's this opening up of the way people are thinking that allows for some really exciting potential movement in the way we've been doing it.
This aligns so well with the core philosophy of care and family medicine. And I think this is an opportunity for family medicine to step forward because your approach to care, as you were talking about earlier, what influenced your thinking, that's shared very deeply by most family physicians in the country and what I call the family medicine movement. So I think there's an opportunity for family medicine leadership here. You know, a couple names come to mind, and I'll just ask if you are aware of these people. Do you know Dr. Jim Mold out of
Uh,
Oklahoma?
no, I don't.
So Jim is he's a National Academy of Medicine um, member. He's also was on the faculty at the University of Oklahoma. He's written 2 books on goal-oriented care, and I'll send you links to them. I think you'd be very interested. I've also done an interview with him, and he's really been working on moving away from the disease orientation to exactly what you're talking about in terms of how do you help people identify what matters to them
Hmm.
and then support that, and how do you do it in the charting, how do you do it to make it a whole systemic response. And the other person is Dr. Wayne Jonas, who I believe you know.
Sure. Yeah, Wayne, we work pretty closely with Wayne. Yeah,
So
absolutely.
his wonderful book, How Healing Works,
Yeah,
also echoes starting off with what matters to the patient and really trying to be driven by that. So I think there's this, call it a focal point, a nexus of energy within family medicine that your work, how do you bring it to life because you bring it into an actual care delivery system, which is wonderful.
yeah. I mean, that's part of why this is so exciting for me is that, this is why I ended up in medicine really. And so, and why I ended up in family medicine. So, um, I do think you see bubbling up around the country that a lot of the leadership in this kind of arena of change is family docs. We have a wonderful assistant undersecretary of health for clinical care in the VA right now. Is basically the VA's CMO, who's very much on board with this kind of approach. Cameron Matthews, she's a family doc, and I think people are ending up in positions where they can really help this kind of um, attitude and this kind of approach move forward, which is it's really exciting. I think it's great.
Yes, I think so too. And I have to thank you very much for introducing me to uh, Dr. Kara Odom Walker.
Oh, good. Did you get to talk to her?
We have had a conversation,
Yeah.
yes, and I'm going to do an interview like this with her
Oh, great. I
sometime in.
barely know her. I mean, we only met on an online panel, but I've known of her. But then when I actually heard her talk and exchanged some of my thoughts with her, I was just like, wow, this person's amazing. So I'm glad you're going to get to talk with her as well. Yeah.
This is great. So I'm going to bring things to closure here. Any final points or any final ideas that you want to add to the stew?
I don't think so. I think I said everything I had to say pretty much. So
Well,
no, it's fun to talk about. I appreciate the opportunity.
I appreciate you talking with me, and I hope you have a wonderful time
Thank
uh, on your expedition.
Thank you. I'm really excited about it. So, all right, great. Well, good talking with you, Larry. I'm sure
Good
we'll talk
talking with
again
you, Ben.
soon. Yep,
Thanks very much.
my pleasure. Bye bye.
Bye.